Thank you, Dr. Johan. That was great, and that sort of segues into what I will be discussing is the pulmonary carcinoid tumors. So Dr. Johan spoke about the high-grade neuroendocrine tumors of the lung called small cell lung cancer. So obviously very much more common than some of the other neuroendocrine tumors of the lung. But occasionally you will see these things, and so it's good to have a little bit of a background. These are my disclosures. So these are the learning objectives. So what we're going to talk about is we really want to define the characteristics of the WHO classification of neuroendocrine tumors of the lung. I'll show you some pictures about the role of endobronchial therapy for obstructive tumors that are very impressive, and then we'll discuss a workup for and a treatment algorithm for patients with lung neuroendocrine tumors. So the neuroendocrine tumors of the lung they really do represent a diverse group of malignancies. So in the lower setting, these are called the pulmonary carcinoid tumors. And then when we have the higher grade tumors, they're called the neuroendocrine carcinomas, so large cell neuroendocrine carcinoma and small cell lung cancer. So the risk factors vary. For the high grade tumors, we think about smoking. That is the number one risk factors. In the lower grade, we can sometimes see a genetic syndrome. So we think about multiple endocrine neoplasia type 1 or newly described type 4. And many times there are no risk factors, and they arise sporadically. Now, neuroendocrine tumors in general, the majority of them happen somewhere in the belly, but up to 25% start out in the lungs. But even though they're 25% of all neuroendocrine tumors, they represent about only 2% of all lung cancers. The incidence of lung neuroendocrine tumors is rising. This is a study from 2017 where they looked at the incidence of actually all cancers and saw the incidence of all cancers is actually decreasing, but the incidence of neuroendocrine tumors is actually increasing. What is increasing the fastest out of neuroendocrine tumors is neuroendocrine tumors of the lung. So we will see these, many times, these get picked up incidentally. So we're seeing more and more of these things in our clinics. So symptoms are very similar to other types of lung malignancies, that recurrent pneumonia, they cough with or without hemoptysis, shortness of breath, wheezing. But interestingly enough, sometimes patients have no symptoms at all, and these get picked up incidentally. Someone comes in preoperative for the knee surgery, and lo and behold, they've got a mass in their chest without any symptoms. So this is one such patient of mine. So this is a 45-year-old woman with a incidentally found lung nodule. So you can see that right there. That is not supposed to be there. So what do we do? Well, we work it up just like any other type of lung cancer, and it all starts with biopsy, labs, and imaging. So I'll talk about this spectrum that Dr. Chauhan discussed. So these are the lung neuroendocrine tumors are classified a little bit differently than the GI or pancreas neuroendocrine tumors. So we break these things into historically typical carcinoid or atypical carcinoid. there's large cell neuroendocrine carcinoma, and then small cell lung cancer. And to define those, what we look at is the mitotic index, so less than 2 mitoses per millimeter square without evidence of necrosis. That is the definition of typical carcinoid tumor. When it goes 2 to 10, with or without necrosis, that's when we fall into atypical carcinoid tumor. Now, you may have seen some atypical carcinoid tumors in your practice, and you say, well, wait a minute here. This is 2 to 10. That's still not that aggressive. Large cell neuroendocrine carcinoma, there's that's an aggressive tumor. So the WHO recognized this finally, and now there's a newer classification of this. So carcinoid tumors or neuroendocrine tumors with elevated mitotic counts and or Ki-67 proliferative index. So that's another category that we have now. And these are those tumors with more than 10 mitoses per millimeter squared and or a Ki-67 over 30%. So that is the newest change on here. So that sort of fills in that gap between atypical carcinoid and large cell neuroendocrine carcinoma. So the next part of the workup is our conventional imaging with our CTs and MRIs. There's functional imaging, so similar to other neuroendocrine tumors, we do this. Now, I put this up here, this Octria scan, mainly for historical purposes. I will say nobody in your practice should ever get an Octria scan. It's an older test that is very cumbersome. It's sometimes a 2-day, sometimes a 3-day process to do this. So the patients are going through a lot, and it gives us these fuzzy images that you really need to be trained how to read. But the dotatate PET CTs have really replaced the Octria scans. If there is a higher grade component of the cancer, or we have an aggressive type cancer, that's when our FDG PET is sometimes useful for these malignancies. So, as was mentioned here previously, every patient really does need to be discussed in a multidisciplinary setting. So you can see these two patients here, big lung mass here and here, evidence of bone metastases. So these are the same diagnoses. These are both typical carcinoid tumors, but we treat them much differently. So when I talk about functional imaging outside of the Octria scan, we do talk about the dotatate PET CTs. So they are superior to the Octria scan. It is a single injection. An hour later, you get scanned, and as I said, there's no reason to ever do an Octria scan. And what's important about this is, so here's your Octria scan. Here's the same patient with a dotatate PET CT. So you can see the difference there. Why we do this is twofold. One is it really helps categorize the extent of disease, but two, it also gives us an idea whether or not these patients will have somatostatin receptors on their tumor, and based on that can have major treatment implications. So there's two dotatate PET CTs that we use in the U.S., the copper 64 dotatate and the gallium 68. Again, both are superior to the Octria scan, and there's similar concordance between the two. In this particular study, the copper 64 found more lesions, and sometimes we see that in practice where patients will start out with a gallium 68 scan, and then throughout the course of their journey, they will have a copper, and it may or may not look different than the gallium. So sometimes it's best to start out with one and follow that. The biggest benefit to the copper is the extended half-life. So gallium really needs to get into the patient very quickly. It needs to be made at a center that can do this, whereas copper is actually made in St. Louis and shipped to various centers across the United States. So much longer half-life. So at Vanderbilt, we exclusively use copper. We have the capability of doing gallium, and the only people who are doing galliums are the people who don't know about copper. So. But there's some pitfalls on the dotatate PET. So most, but not all, the neuroendocrine tumors have somatostatin receptors. So you may get a patient with a dotatate negative CT, but they still have a neuroendocrine tumor. There's sometimes some false positives. Back when we first started doing this, we would see uptake in the pancreas unsnit process that would sometimes fool people, and patients would get these. They get their reports faster than we do, and they say, "Oh wait, there's uptake in the pancreas. Do I have pancreas cancer?" Well, no, that's physiologic. Sometimes degenerative bone disease can cause this fractures. Sometimes reactive nodes or post-radiation therapy can cause this. We're picking up a lot of meningiomas with these types of scans, and some other types of cancers can show some uptake. As I mentioned, there's some variability between the two scans, and importantly, one of the things we see on the PETs, especially the FDG PETs, we talk about the SUVs, right? So the higher the SUV, usually the more aggressive type cancer. With the dotatate PET CTs, we really don't know what to make of the SUVs, and so really, it's because a lot of it goes into people are sometimes on a somatostatin analog that can cause some differences in the uptake on the scans. So really, it's a yes or no type question. Do they have somatostatin receptors or not? So rather than focusing on the SUVs to determine progression, look at the sizes more than anything. Okay, so some of the things that we think about when considering treatment for neuroendocrine tumors of the lung. Obviously, stage goes into this. Symptoms. Again, the presence or absence of somatostatin receptors. What's the tumor burden look like? What's their comorbidities? Importantly, in this field, we want to look at lung function. So there's this prime real estate, and then obviously patient preference. So early stage. Pulmonary carcinoid tumor treatment is surgical resection. So generally we will follow the treatment guidelines for non-small cell lung cancer with lobectomy, usually being that gold standard. But there can be a role for sublobar resection with mediastinal lymph node dissection. There is a role for stereotactic body radiotherapy or SBRT. I think in some cases this was thought to be a radio-resistant disease. These cancers love radiation, so it works. It works well. So those patients who are not candidates for surgery or decline surgery, SBRT can be used. And importantly, adjuvant therapy is not recommended. So there's many studies that look at the role. Clearly in non-small cell lung cancer, high-grade neuroendocrine carcinomas, we have lots of data that support the use of adjuvant therapy. In the pulmonary carcinoid tumors, there are no large studies that tell us this does anything. So when you get that patient with an atypical carcinoid that is node positive, and you really want to give them something, don't do it. All right, so this is a interesting type of cancer that can sometimes arise endobronchially. So this is a patient of mine, a young guy. I think he's 30 years old. Just had his first. Him and his wife just had his first their first baby, and so he comes in with symptoms of wheeze and dyspnea over several months, and so he gets this scan, and so what you can see here is this this in the all right there. So that's obstructing his airway. So what we can do is something called endobronchial therapy, and there's several different varieties. We break this into cryotherapy or thermal therapy or laser or photodynamic therapy. So essentially, it's meant to get rid of that lesion within the bronchial tube. So you can see this particular patient, he started out with this in his airway. This is during the treatment, and then this is after the treatment. So fast forward 6 weeks, they go back, and we see the airway is pretty open. He's got this little thing that may or may not be anything right there, but they elected to treat it again. And then fast forward to 8 months, you can see it looks pristine. Importantly, if this recurs, this does not negate the role for surgery. So this is the pre and the post. And he is doing well and completely asymptomatic now. All right. So this is a patient of mine. So 70-year-old with typical lung carcinoid. Now again, slow-growing cancers, they shouldn't do this, right? But I can tell you, they can. And so you see that you don't see this all the time, but you certainly see this from time to time. So what options have? Observation. We can talk about that. There's somatostatin analogs. Dr. Chauhan talked about the radionuclide therapy, and I'll discuss some of that as well. Chemotherapy, maybe some immunotherapy. Then there's our targeted therapy, liver-directed therapy, and please don't forget about clinical trials. All right. So why in the world would you ever observe a patient with a malignancy? Well, some people come in and they have a scan, not a scan that looks like that, but maybe has evidence of disease in several areas. But we look at it and maybe this was picked up incidentally and the patient is asymptomatic. And you look back and you say, wait, Miss Jones, you had a scan done 4 years ago for something or another. Oh, these nodules were there 4 years ago and they haven't done anything. So that is, and you biopsy it and it's typical carcinoma. All right, so if you have a patient like that, sometimes you don't necessarily need to rush to treatment with these patients. So if they're asymptomatic, low burden of disease, if they're typical carcinoid tumors, these are the patients that maybe you can safely observe, but don't let them disappear. You need to continue to follow them with imaging, and then once they progress, then talk about treatment. So usually the first treatment option for patients with neuroendocrine tumors of the lung that are somatostatin receptor positive is a somatostatin analog. So there's two of them. One is octreotide LAR. The other one is lanreotide. These are both Q4-week injections, and they help to control the disease growth. Unlikely to make it shrink. And you can see there's two studies here, one called ProMid and the other one called Clarinet, which showed an improvement in progression-free survival. but I will caution you, these were in midgut neuroendocrine tumors and gastroenteropancreatic neuroendocrine tumors, not lung. There was one study, one prospective study, that tried to assess the role of lanreotide in lung neuroendocrine tumors and randomized patients to 2-to-1 to either lanreotide or placebo. And what they found was, one, is a hard trial to accrue to. This trial was stopped early. They had wanted over 200 patients. They ended up getting 77 patients. We were the number one accruer in the country with 3 people on trial. So it's a tough study. But what you can see is there was some benefit to the lanreotide seemed to be more impressive in patients with typical carcinoid rather than atypical. So this study, interestingly enough, was presented in 2021 and has not yet been published. So take it for what it's worth. All right, so what about beyond somatostatin analogs? So you have a patient who has that somatostatin analog and they're starting to have some evidence of progression, or maybe you get a scan on a patient, a dotatate scan, and they're dotatate negative. All right, so what do? Well, you go to the only FDA-indicated treatment for this, which is everolimus. So this was a study that randomized patients with GI or lung nets to everolimus versus placebo, and we can see there was a benefit of 11 months versus 4 months for placebo. So we try not to do placebo-controlled trials anymore, but this was published in 2016. So nowadays, we may have another option that we're waiting publication on. This was the CABINET trial that looked at patients with pancreatic and extrapancreatic neuroendocrine tumors and randomized them to cabozantinib versus placebo. And their study was endpoint was progression-free survival. Importantly, patients needed to have progression or intolerance of at least one prior FDA-approved systemic therapy, not including a somatostatin analog. All right, so these were the baseline characteristics. I just highlighted the number of lung patients on here. So 27 lung patients actually received the cabozantinib, which is a pretty good number for these types of studies. And this was the extrapancreatic cohort progression-free survival. So cabozantinib, 8.3 versus 3.2 months. So it's not setting the world on fire, but it's another option that we may have for patients. So Dr. Chauhan mentioned radionuclide therapy. So this was FDA approved in January of 2018, but has been given for a long time outside of the United States. So this particular study looked at patients with metastatic or locally advanced midgut neuroendocrine tumors, grades 1 and 2. You needed to have a Ki-67 less than 20%. And randomized patients to either the lutetium dotatate versus high-dose octreotide LAR, so 60 milligrams. If you don't know, 60 milligram, the octreotide LAR, big injection in the behind, once every 4 weeks. Nobody enjoys doing it. High dose, the maximum amount of dose per syringe is 30 milligrams. So these patients had to get 2 of those injections every 4 weeks. So here's the outcome, very significant improvement in progression-free survival. Overall survival did not meet statistical significance, and likely because there was quite a bit of crossover for patients. But interestingly enough, we can see that the response rate was only 18% in these patients. So again, if I get a scan on a patient, I need to prepare them to say, well, if I get a scan on you after your treatment and it looks exactly the same, we're in good shape. So again, caution that these were midgut neuroendocrine tumors. So the newest data is looking at patients with the higher grade neuroendocrine tumors upfront treatment. So rather than having to wait until there's progression on a somatostatin analog, the NETTER-2 study was presented at GI ASCO in January and randomized patients with low-grade 2s, so the Ki-67s, 10%, all the way up to the well-diff grade 3 with Ki-67 of less than 55%. Randomized them to lutetium dotatate versus high-dose octreotide LAR, and then there was an optional extension phase. So this was the data that was presented. So median PFS of 22.8 months versus 8.5 months. So very, very significant improvement in progression-free survival. Interestingly enough, this did have a overall response rate of 43%. So remember, the NETTER-1 was only 18%. So this was in the upfront setting, and the higher grade tumors seemed to be more responsive. So this is another study that was just presented, and we're waiting for the publication. PRRT for lung nets, we do it. It's on all the guidelines. We don't have prospective data to suggest that this is beneficial, but we certainly extrapolate. There's a lot of retrospective data. There is one clinical trial that it's a cooperative group study that looking at patients with unresectable lung neuroendocrine tumors and then randomizing them to either everolimus versus lutetium dotatate. And then there's crossover after that if they progress on everolimus. Okay. What about immunotherapy? We've heard a lot about immunotherapy in this meeting, and others. It's really, we use this for many different cancers. But in the neuroendocrine world, the results of immunotherapy have really been disappointing. So overall response rates usually in the single digit overall. But there was a trial looking at spartalizumab in neuroendocrine tumors and neuroendocrine carcinomas, so overall response rate of only 7%. But in the lung cohort, it was over 16%. So maybe there's something there. There is data to suggest the role of combination ipi-nivo showed some benefit for patients with neuroendocrine tumors. So this particular study had 11 lung net patients in there, and they had a 33% response rate. So these are things that this is, something that I will use in my patients sort of once I've gotten through everything. It's not on guidelines, but when you have that patient in front of you, you say, well, there's data for this, and I've seen some dramatic responses with this. Combination chemotherapy, again, people say, chemotherapy doesn't work with the neuroendocrine tumors. It does. This was a study, a retrospective study looking at the use of capecitabine and temozolomide in lung nets. Not a large population, but just 20, but nonetheless had about a 30% response rate. So we certainly will use this, and most people tolerate it pretty well. So importantly, more research is really needed in this in the neuroendocrine space, and particularly the lung neuroendocrine space. This was a abstract we presented at NANETS a couple of years back, where we looked at all the neuroendocrine tumor research of the lung neuroendocrine tumor research between the largest neuroendocrine meeting in North America, which was NANETS, and the largest lung cancer meeting in the World Lung Cancer Meeting. So overall, this was a number of all trials, and we can see the ones that include lung nets are sort of on the bottom. Similarly, at the World Lung Meeting, 17,000 abstracts, so going back to 2013, and only a handful of lung net abstracts. And most of those, I can tell you, were clinical vignettes, retrospective series, these kind of things. There were no clinical trials presented. So this is sort of a busy slide. Talks about how we work up and treat this. Importantly, it really needs to be in a multidisciplinary setting. So we meet every week. We do 2 different tumor boards. We do our neuroendocrine tumor board, and then we do our lung tumor board as well. So these people can live a long time. So it's all about timing with these patients. So I'll conclude saying that neuroendocrine tumors of the lung, they're uncommon and really do need that multidisciplinary approach. Surgery is the first line treatment for early stage neuroendocrine tumors of the lung. We talked about endobronchial therapy, so always involve your interventional pulmonary folks. Even though there's only one FDA-approved treatment for neuroendocrine tumors of the lung, many options do exist. And the lung nets really are poorly understood, and more research is required. So I'll stop there and happy to entertain questions.
Dr. Ramirez, can you talk about atypical lung tumors?
I did.
And just like that, Berners patient where it didn't meet large cell criteria, didn't meet small cell, guy 67 around 30, but they still called it like atypical.
Mm-hmm.
Back down, move through it, and then put them pretty quickly onto a platinum doublet. You like imaging characteristics, how much it lights up on a scan?
Yeah, so that's a really good question, because you can't really, you got to remember that many of these patients are getting small biopsies. And so where you put the needle in one area, your Ki-67 may be 30, and you put it a millimeter away, and it may be something much higher than that. So really, you really do need to look at how the patient is, what's actually happening with the patient. If you think that, again, I talked a lot about the dotatate PET CTs. If you think you have a more aggressive tumor, the FDG PET is indicated, and these are, usually, you'll get uptake on an FDG PET in typical carcinoids, but your SUVs are going to be 5 or 6. If you get an SUV of 100, then you're dealing with a more aggressive tumor, and so yeah, that's where I'd probably treat it more along the lines with platinum.
Great talk. You mentioned the implication of nodal disease. So we do alone for carcinoids, atypical, and there's positive nodes. Basically the teaching that it's prognostic. But what are you doing with those patients in terms of surveillance?
Yeah, so a great question, because these are patients that you take out the nodes, and maybe there's disease in 10 mediastinal nodes, and what do you do? And the thinking is, I've got to give them adjuvant chemo. They're gonna recur. But the data tells us that adjuvant chemo, one, there's no data that says it's beneficial, and there's quite a bit of data that says it's detrimental, actually, and patients do worse if they get adjuvant treatment. So usually with these, you monitor them with scans. Usually I'll do 6-month intervals. If we get to 2 years, then I'll space things out, usually yearly. It sort of depends on if it's atypical or typical. But yeah, these are patients that get followed for a very long time. So the guidelines tell us 10 years. And then at 10 years, we have that conversation about, do you feel comfortable, not getting a scan next year?
Do you survey with dotatate or CT?
Usually CT. If there's any evidence of growth or changes on the CT, then I'll get them a dotatate. All right. Well, thank you very much.